All right, while we're waiting for the others to join, we can get started. So welcome to our webinar this evening. This is the third session of our STI and BBV refresher series. My name is Jamie and I'm a primary health trainer from WAFA. But before we get started, I just want to do an acknowledgement of country and pay respect to the traditional owners and elders of the land that we are meeting on today. Recognizing their diversity and the significant importance of their cultural heritage, values, beliefs, and self-determination in contributing to the positive health and well-being of the whole community. Just so that you're aware, this webinar will be recorded. We have been publishing the last few webinars we've done on our YouTube channel under the playlist STI and BBV Refresher Series. So if you haven't been able to attend, please go back and check those out. If you do have any questions throughout the webinar, also feel free to pop them in the chat and we will have time for some Q&A at the end. I also just want to introduce our speaker for this evening is Dr. McAvoy. So she is a public health physician at Blue Public Health Unit, and she has an extensive experience in communicable disease control. So without further ado, I will pass over to you.
Thank you, Jamie. So this evening I'll be talking about contact tracing and follow-up of STI diagnoses. And just to make you aware that this is one of 4 seminars that are being held. And previously we've had one on STI testing, STI results and treatment, and of course an upcoming session coming up about hepatitis C. And in tonight's session I'll be talking about chlamydia, gonorrhea and syphilis notifications. I'll be talking about contact tracing, as in who is a contact, why it's important, and of course for busy GPs, how can that help? I'll also then be talking about follow-up of STI diagnoses, including when to retest and some prevention advice. So to start off with, this shows chlamydia notifications in Perth between 2000 and 2024. And as you can see, there was a really steep increase until about 2011, and then a stabilisation, a really high level, with a little bit of a further peak in 2023 and 2024. So now we're getting over 10,000 cases of chlamydia in Perth per annum. And for gonorrhea, it's a similar story. We've had a very sharp increase. We did have a COVID-related dip in 2021-22, but unfortunately we've now returned to the trajectory that we were following before that, and we're getting just under 4,000 cases of gonorrhea per annum. And in relation to syphilis, so our case of infectious syphilis in the early 2000s was really low. And then between about 2006 to 2015, we started to get about 50 to 100 cases per year. And that was mainly among the men who have sex with men community. And then since 2016, we've had a really steep increase until 2022. And this is marked by lots of different changes. For example, heterosexual transmission became more common. So we've had many cases in women of reproductive age and in people who've been pregnant, including then case of congenital syphilis. We've had increasing number of cases in Aboriginal people, people with unstable housing, and people who are using illicit drugs. Now, in 2020, the WA Chief Health Officer declared an outbreak of syphilis here in Perth. But at the time, public health resources were diverted into COVID. So it wasn't until 2022 that our public health unit was able to set up a syphilis response team. Now, happily, we have had a little bit of a reduction in cases in 23 and 24, but early information from 2025 show that we are starting to go up again, unfortunately. So it's still a work in progress managing this outbreak. And interestingly, just today, the Commonwealth Chief Medical Officer has declared syphilis a communicable disease incident of national significance because case numbers are increasing, not just here in Perth, but across the nation. So this means contact tracing is super important. And contact tracing is basically the process of identifying, assessing, and managing contact persons of infectious individuals. So a contact in this context is anyone who has had sex, be it oral, anal, or vaginal, with a person who has a confirmed STI. And noting that for some STIs, this can include intimate skin-on-skin contact without necessarily intercourse. So, for example, if there's a syphilitic lesion, you may not necessarily have to have intercourse. It's just direct contact with that lesion. And the other group of interest, of course, are unborn babies and the infants of women with untreated STIs. And this is because of vertical transmission, so the baby can get, for example, syphilis in the womb, or they can get STIs as they pass through the vaginal canal. So who's responsible then for contact tracing and look back? Well, diagnosing doctors should ask about contact tracing and assist where possible. Now, the look back period will vary depending on the disease, and in the case of syphilis, on the disease stage. And doctors need to be thinking about the upstream contacts, in other words, who is it that has infected your patient, but also the downstream contacts, in other words, who are the people who may have then been exposed to your patient while your patient was infectious. So then let's look at those periods in a bit more detail. So for infectious syphilis. Now, primary syphilis is the syphilis that's characterised by having a chancre or lesion or lesions. And for primary syphilis, the look-back period is 3 months prior to the symptom onset, and also the length of time they've had their symptoms. And just noting that anyone who gets treated should be instructed that they need to abstain from sexual activity for at least 7 days after their treatment date. For secondary syphilis, which just again is when the symptoms are more of a systemic nature, so people then get maybe lymphadenopathy, rash, fatigue. For those people, you need to go back 6 months prior to symptom onset, plus the entirety of their time while they've had their symptoms. Early latent syphilis is infectious syphilis, but where there are no symptoms. For those people, we need to have a look-back period of 12 months. But it's important for GPs to do a careful history, because someone might say, well, I have no symptoms now, but maybe two months earlier, they might say, well, I had a genital ulcer back then. So in which case, in that example, you would go back a full 14 months. For chlamydia, you need to contact trace all partners for 6 months, and for gonorrhea, a minimum of 2 months. But of course, contact tracing can be really challenging. So how can GPs who are busy help? So it's important to talk to your patient about how to notify their contacts, and this can sometimes be done in person if your patient is comfortable to do so. Some may prefer telephone or SMS, or privately messaging through social media. But another thing to be aware of is online websites that can anonymously let partners and sexual contacts know. And these contact tracing apps include Let Them Know, which is for a general audience, The Drama Down Under, which is for MSM and related groups, and Better to Know, which is catering for Aboriginal and Torres Strait Islander people. Now, in some instances, GPs will find that it's all very complex. For example, someone might have many sexual contacts, or might tell in their history that they might be engaging in sex work, in which case then a referral to specialist sexual health services might be indicated. And of course, public health units can also assist, but if you would like that, then do forewarn your patient that public health will contact them. And so when you're talking about contact tracing, it's important for it to be clear that it's a private discussion. It's important for clinicians to be non-judgmental and not make assumptions, for example, about the number of sexual contacts someone might have or the sex of those contacts. And it's important to ask open-ended questions. Given the look-back periods can be quite long, sometimes relating it to events can be useful to trigger memories. So, for example, New Year, birthdays. And if you are going to get public health to assist with contact tracing, then it's important, if it's possible, to get some identifiers about those sexual contacts, including name, date of birth, and phone numbers. So now I'm going to show a kind of a representative example of a contact tracing that we were involved with earlier. So first, there was an Aboriginal woman in her 20s, presented with a painful genital lesion, and was found to have syphilis PCR positive on reflex testing. So just noting that the initial request was for herpes simplex only, but some of our labs do reflex testing. So syphilis had been added automatically by the lab. So that person had some subsequent syphilis serology and had a positive serology with an RPR of 512, so highly active disease, and was diagnosed with primary syphilis and named 2 contacts. Thereafter, there was a non-Aboriginal pregnant woman in her 30s. She too had genital lesions with PCR positive and RPR of 64. So again, the diagnosis was made, primary syphilis, and that person named 2 contacts, one of whom happened to be the same as the earlier case. And so in trying to find then that common contact, we were able to find that person, and they were tested. They were asymptomatic at the time of consultation. They had positive syphilis serology, an RPR of 512. A diagnosis of early latent syphilis was made, but there was no further contact information that we could ascertain from that individual. And then finally, there was another non-Aboriginal woman in her 20s who received some opportunistic testing with her primary care provider. She was asymptomatic at the time of the consultation. She too has a positive syphilis serology with an RPR of 32. Now, she'd had a negative serology within 2 years, so therefore we could classify her as early latent syphilis. And she named 4 contacts, one of whom happened to be case 3. So as you can see, the networks can be quite, there can be quite broad networks, and we need to track those down as part of our contact tracing efforts. And happily, treatment has been given due to the efforts of our primary care providers and ourselves in making sure that this has occurred. So now for follow-up of STI diagnoses. So for infectious syphilis, it's important to repeat the syphilis serology on the day of treatment. This is because the RPR provides a baseline to measure treatment response. And essentially what we want to find is at least a 4-fold drop in the RPR. So repeat testing at 3, 6 and 12 months post-treatment is needed. And that's also a good way to monitor for reinfection. For chlamydia, a test of cure is not routinely recommended with the exception of pregnancy. So if someone is pregnant, then you should retest, but you should do so no earlier than 4 weeks after their treatment. For the risk of reinfection, it's important to consider retesting at 3 months. For gonorrhea, a test of cure should be performed at 2 weeks after treatment completion. And it's important to test all previously positive sites. So for example, if someone has had a positive urine but also a positive genital swab, for example, then you would need to test both those sites. A test of reinfection can be done at 3 months. And of course, that's particularly important if, for example, contact tracing has been incomplete. Another scenario that might happen in general practice is that you have someone who comes who says, oh, I actually received something, an anonymous text message from Let Them Know about being a contact of syphilis. So in this instance, a careful history and exam will be needed, and that would include whether there are or have been any clinical symptoms and signs. Testing for a full STI and BBB screen will be needed, even if they're asymptomatic, and appropriate counsel needs to be given. And of course, there may be times when you might want to consider empiric treatment based on risk. So for example, if a person has symptoms or has had suggestive symptoms, or if you're concerned that the person may not come back for follow-up, then empiric treatment should be considered. Follow-up should be 1 week later to discuss results and provide treatment if needed. For syphilis, it's important to remember that if they do test negative on that initial test, that they should have window testing at 3 months. This is because it can take up to 3 months for the syphilis serology to come up positive. At the time, you might also want to consider a repeat BBB screen. So of course, why are we so concerned about contact tracing and reinfections? Well, it's partly because co-infections and reinfections are relatively common. So we've done a review for the last 2024 to look at that issue of co-infections and reinfections. So co-infections essentially having more than one STI during a single episode, while reinfections are subsequent STI diagnoses more than 3 months after a previous notification. And we found that we had about 8% of our STI notifications are for co-infections, and about 8% of our notifications are for reinfections. So that amounts to over 1,000 notifications for each of co-infections and reinfections. So it's quite a large number. So therefore, prevention is really critical. So GPs need to counsel their patients. So talk about condom use. It is highly effective in preventing gonorrhea and chlamydia. And it's also effective for syphilis prevention, provided the condom is a barrier to the lesion or lesions that the person may have. It's really important that people understand that STIs can be transmitted through oral sex, and that's especially so for syphilis and gonorrhea. And also that sometimes it can be close sexual contact without intercourse. So, for example, if there's a syphilitic lesion, or say if there's mpox lesion. Contact tracing is really vital, otherwise reinfections do occur. For chlamydia, sometimes patient-delivered partner therapy can be supported. There are some sexual health clinics that do that and some jurisdictions around Australia that support that. Regular STI testing may be warranted for some patients, for example, those patients who are on PrEP. And for others, it's really important for them to know to return for testing if they're at all concerned. So, for example, if they have symptoms, a change of partner, or if you've determined any other risks. So these are some really important resources that can assist in terms of the management of STIs. And of course, we at Boolaroo Public Health Unit can assist with those diseases that are notifiable, STIs that are notifiable. And we also have a web page, which is shown there on the right-hand side. And I'd just like to end by acknowledging the staff at the Boolaroo Public Health Unit who are involved in the public health management of notifiable STIs. Thank you.
Perfect. Thank you, Dr. McAvoy, for your time and your presentation this evening. And I want to thank everyone for joining us. We don't have any questions, which is great. So I will move on to the QR code. This is just for any feedback that you have based on this webinar this evening. It's really helpful for us to see how you found it. And if you have any suggestions for topics in the future, it'd be great to let us know via that survey. But on behalf of myself and Dr. McAvoy, we thank you for joining us this evening and wish you a good night.